Welcome to Dark Side of Therapy. I'm your host, Eric Nance, and today what we're going to do is a critique of one of my new favorite therapists on YouTube. His name is Dr. Todd Grande, and I came across this guy just doing a YouTube search, kind of looking at what other therapists were doing. And Dr. Grande is a licensed professional counselor out of Delaware. He's also a psychologist, but apparently is not licensed through the Board of Psychology. I don't know why. I'm not going to ask that question. He does have some haters, though, I noticed. There was actually an article written about him, calling him an armchair therapist, and the person writing the article said no therapist should ever make any kind of analysis unless they've met the person. And I have to say, I harshly disagree with that, because what he's doing, and he actually says this in all his intros, he's not making claims of diagnostic accuracy, and he's not saying this is the way it is. He's offering an opinion. This is his opinion. And he does a lot of opinion videos about things that are happening currently. School shootings, for example. He'll talk about those. The Casey Anthony case, Scott Peterson case. I think this is really enlightening because there are people that want a psychological perspective about this stuff. And in the media-driven world we live in, it's so often sensationalized. So I really commend him for having the courage to break some things down through a psychological perspective. So today, again, I am going to critique his critique of 6 ways your therapist might
Welcome
be
to my
bad.
scientifically informed insider look at mental health topics. If you find this video to be interesting or helpful, please like it and subscribe to my channel.
Hello, this is Dr. Grande. Today's question is, what are the signs of a bad therapist? This was a question from a subscriber. I've also seen this question many times before. So I decided to format this video as 6 signs of a bad therapist, or really 6 signs of a less than ideal counselor. So I'm using the word counselor here not necessarily to refer to a particular professional identity, but anybody who can deliver therapy. So a professional counselor would be included in that, but also a social worker, psychologist, marriage and family therapist, or some other similar profession. I'm also talking here in terms of signs as a bad counselor in general, not necessarily someone that's not a good match. Because sometimes a counselor can be very effective and good for most people, but not effective for certain individuals. So that's something to keep in mind. I'm really looking again here in general terms.
So one thing I really like about what he's doing here is his disclosure statement is basically saying to you, here's what you're going to get. And he talks about it in terms of there's going to be some general stuff here. And so before you watch the video, you have an idea of what you're getting into. And that goes back to what I said earlier. He's not saying this is completely precise. This is my interpretation.
It's also worth mentioning here that most counselors are good. This video is focusing on a lot of negative aspects, specifically 6 negative aspects that might be seen in the world of counseling, but the vast majority of counselors do a good job under a lot of different circumstances.
So when Grande said there's a lot of good therapists out there, not too many bad ones, that's highly debatable, because I think there is a spectrum of therapists, from a lot of super, super good ones to ones that aren't so great. And I base it on client feedback and also therapists I've interacted with and some of the techniques and strategies they use. So I think when he says this, that might be a bit misapplied.
The problem is that just a few counselors can do a lot of damage. That's one of the reasons I decided to answer this question. I think it is an important question. Now, when I use the word bad here, I'm not really referring to bad versus good, but again, less than ideal, or not competent, or less competent than preferred, something like that. Now, some of these signs are very bad indicators, and others really have to think through and look at other circumstances before making a determination that somebody's less than ideal in their role as a counselor. I also tried to make this list fairly objective. There's a lot of subjectivity with this topic. I searched this topic on the internet, and you see all these different websites and videos that offer these really ambiguous lists.
Yeah, I completely agree with Grande on this, and I think if you look up what a bad therapist is, you're going to get a plethora of responses from Google. So I like the fact that he's isolating it a little bit and being fairly specific. Still a little bit general, but I think is doing a much better job than if you go out and search bad therapist on Google.
They have items like you're not clicking with your counselor. That's not very easy to define. Or they'll use statements like too, like TOO, like too much empathy or too little empathy or too active or too passive. Really, these terms have meaning, but it's very hard to determine what level is too much. So I tried to, again, make these more objective anchors that are a little easier to at least observe. Again, though, there's always some subjectivity when you come to an issue like this, and a lot of variables need to be taken into consideration. So the first sign of a less than ideal counselor I have is what I refer to as the story. And I've heard the story many, many times in my career. And what the story means is when a client asks a counselor if they have a license, which most clients probably wouldn't have to ask because they would know, and it's not really a question that comes to mind readily because a lot of people don't understand licensure very well, which is actually quite understandable. So when this question is asked, there are all kinds of potential stories that come out other than just yes or no in the explanation. So they might say, well, it's complex. You ask them if they have a license, say, well, it's complex. Well, it's a long story. Or I almost have a license, but my supervisor didn't sign the form because they disappeared in a hot air balloon accident.
This one's a little baffling to me because every agency I've worked at goes through a meticulous process to make sure you are licensed and can provide therapy. I can't imagine an exception there. And so I'm wondering where Grande's getting his evidence of this, who he's interacted with. I'm also wondering if maybe he's talking more about a private practice clinician who is then saying they have credentials they don't, or misinforming the client about their credentials. But again, I'm just wondering how a person could even set that up, because the absolute amount of deceit that would go into that is mind-boggling. And maybe in today's day and age, somebody could pull it off, but I find it staggering that any therapist would be able to get away with this for any length of time. Your board would come down on you in a tremendously bad way. I have heard of situations where, for example, in my discipline, social workers have applied and gotten jobs where they have misrepresented themselves as licensed. There are some jobs you have to be a licensed social worker, say at the bachelorette level, and I've watched them get in trouble for saying, yep, I was licensed and I wasn't, and yet they're working the job, misrepresenting themselves that way. But he's more or less talking about therapists that have done this, which is really staggering to me.
Or they were selected to be an astronaut, now they're on their way to Mars, or some excuse as to why the normal course of events that would lead to licensure didn't lead to licensure in their instance. Now, again, if somebody just says, no, but I have an explanation, no, but I'm working on it, no, I don't have the money, or something like that, I can understand that. But what I don't really like is when there's this whole complex story. There's this whole story that's using the technical language of counseling, like supervision and things like that, where the client might not know what that means. So they might think, oh, well, their supervisor disappeared, but that means they're still licensed. They wouldn't really know. Now, of course, there are valid explanations. If somebody's an intern, they wouldn't have a license. So that's just something somebody would tell you. We would hope. I'm an intern, therefore I don't have a license. And one area I do see where it gets a little complex is this associate or graduate license. Like the state of Delaware has a licensed associate counselor of mental health. So it's technically a license, but they're not licensed to independently practice. So the answer would be yes, but there'd have to be an explanation. It's an associate license. I'm not fully licensed as an independent practicing professional. But again, oftentimes we hear the story instead. We hear this whole complex set of sometimes really fantastical reasons as to what prevented the individual from getting a license. Now, I know in the counseling profession, of course, there's a lot of preparation. There are a lot of things that can legitimately go wrong. Sometimes supervisors do disappear. Sometimes people don't have the money to pay for the license. All kinds of things happen.
I am taken back at how often he seems to be saying this actually occurs, even though it is confusing in our profession, the different degrees of licensure. So, for example, as a licensed clinical social worker, I can bill insurance. I can't as a licensed graduate social worker, which I have to be before I'm a licensed clinical social worker. I had no idea this was happening with the frequency that Grande's pointing out. And it really gets me curious if, in fact, this many numbers of therapists are actually being fraudulent with their credentials or misrepresenting who they are. That's scary to me.
I'm just really talking about being upfront and not weaving it into a complex story that potentially a client would not be prepared to understand at a technical level. So the second sign of a less than ideal counselor would be when somebody has a doctorate, not in a counseling related profession, but again, if you ask them about it, they hem and haw and kind of give you a big story. So just to understand the ethical requirement, if somebody has a master's degree and they get licensed at that level, they're a licensed professional, whatever that is, counselor, social worker, whatever. In order for them to refer themselves as a doctor, that doctorate has to be in a counseling-related or mental health treatment-related field. It can't be in something completely unrelated. So for instance, if somebody has a doctorate in biology or art history or something like that, that's an interesting doctorate. Either one of those is interesting, but it's not enhancing clinical skill. So therefore, they really couldn't use that.
He is spot on with this. You cannot represent yourself as anything other than what you are in the mental health field. If you're not a doctor, you can't say you're a doctor. And if you're not a psychologist, you can't say you're a psychologist. Or if you are a psychologist, you can't say you're a clinical social worker. I have clients all the time say to me or refer to me as their psychologist, and I say, I'm not a psychologist, I'm a licensed clinical social worker. A lot of times they don't know what that means, so I have to explain what that actually is. But Grande has this absolutely true. Now, I found out, though, this is really interesting. Doctor is not a protected title. It is not a protected title. That's how Dr. Seuss got away with it. There is no protection for the term doctor. However, in our field, there's an ethical principle behind not saying you're a doctor, because a doctor is going to imply a different level of competence and education than you may have.
They couldn't say, well, I'm a doctor. Not in that context. They could say, I have a doctorate, but it's not one related to counseling, so I'm operating here at a master's level, and that's fine, but they can't call themselves a doctor. It's actually, of course, an ethical violation, and some degrees are right on the fence, and these are debated, like some PhDs or other types of doctorates, like sociology. I've heard people debate that in both directions. That's why I use the standard clinical skill being enhanced. That's the standard I use. So if somebody's doctorate adds to their clinical skill, then that makes a much better case to use the term doctor than if it didn't add to the clinical skill. So again, with a degree like sociology, you'd really have to look very carefully at that degree and say, was there actual clinical skill added to the skills that were learned before, or were there new skills added that are related to the profession?
What also comes to my brain when Grande is talking is, as therapists, we have a duty to protect the public. So to the extent that people are misrepresenting their credentials, that's really dangerous. We can't do that. And again, the frequency with which he's saying it occurs really frightens me. Most people that I know, in fact, I can't think of a therapist I've worked with through the years has ever misrepresented their credentials, at least certainly not intentionally, but I can't imagine it happening unintentionally either, unless somebody was trying to be deceptive. But nobody that I've known has ever tried to do that, to my knowledge.
The third sign of a less than ideal counselor would be when a counselor introduces the idea of being a friend during the time when therapy is occurring, like during the time when somebody is a counselor's client, or suggests that it's a possibility for the future. Like, hey, after this therapy is over, we'll be good friends. No, that's not something that's acceptable. And we could look at romance as being even worse. If somebody suggests a romantic or sexual relationship, that's not only a violation of ethics, that's illegal in most places as well.
Now, Grande is completely spot on with this one. As therapists, we cannot be friends with our clients, particularly during the therapeutic process. But there is debate about what happens after the therapeutic process. And I even went and re-reviewed one of the boards I'm associated with, their policies. And I kid you not, there is a statute in there that says we actually can have a sexual relationship with a client 2 years after the termination of therapy, provided certain requirements are met. It's just surprising to me. Now, I haven't checked other boards. I don't know what other boards say. I would understand and believe there's a lot of continuity between them, but I bet there are some differences too. My problem is this. There is such a power differential in the therapeutic alliance where the client generally understands that the client holds a degree, or the therapist holds a degree of power, and that can so easily be abused. Certainly during the therapeutic relationship, but after too. Because I'm wondering, how would a therapist and a former client ever recover from their former relationship and then have a sexual relationship or even a friendship? It would be like having to design the relationship anew, and I can guarantee you neither one of them is going to forget the prior relationship. This has happened to me. I've had a client or two who have tried to be my friend, have talked about what it would be like if we had beers together. And it's always a tricky place to be because I've said things like, if we weren't in the therapy office, boy, I would love to be your friend. And we would probably get along well. And back in the day, I had a situation where a woman actually said to me in the middle of our therapy session, I look forward to when therapy's over because we could be Facebook friends, we can do dinners, we could do this. And I was a lot younger. And I think I made up some lame comment to get out of the whole conversation. And I was scared to death. I think they don't prepare us real well for how to deal with these kinds of situations. And looking back, what I would have done is what I've instructed everyone to do that's taken my course, which is put it in writing that first or second session when you do up your therapeutic contract or agreement. We can't be friends. Because then when it does come up later, you can say, you know what, we agreed to this, you signed off on it, and that usually takes care of the whole conversation. But if you don't do that, you can get submarine like I did. I believe real strongly in something George Harmon talks about. He's a clinical psychologist who does a lot of trainings in the DSM and also in supervision. He says that once a client, always a client. And I strongly believe that. And I think, again, we have to be so careful about the power differential between the therapist and client.
Now, the friend question, of course, is more complex when you talk about post-termination. So when counseling's over, can a counselor be friends with a client? That's a real murky area. I would say, in general, that should be avoided. Now, what's arguably as complex, but certainly more debated, is can a romantic or sexual relationship occur after the termination of therapy? I say no. I say there should be a lifetime prohibition. I don't really see any good coming out of making that okay at some level. The codes of ethics generally disagree with me on this. So with counseling, with the American Counseling Association, there's a 5-year limit. But again, it's the counselor's responsibility to make sure that no harm will occur even after the 5 years.
I mean, don't you find it staggering that you have two therapists, he and I, sitting here basically saying you should never be friends with a client after termination, and so many of our boards disagree? I think that disparity is really interesting and worth looking into because I'm quite frankly shocked sometimes at the things that we uphold that our boards don't necessarily uphold.
With the National Board of Certified Counselors is a 2-year limit. So I understand why they do this instead of making a lifetime ban. But my concern is that counselors may think about those time limits, and that may change the dynamic of the relationship. They may try to end therapy early, or they may make plans even if it's 2 or 5 years out. So I just think the potential benefit, meaning allowing a couple to be together that wants to be together when it's many years later, does not outweigh the risk during therapy. That's my logic for it. But again, this is really debated. I wouldn't say it's extremely frequently debated, but it is something that comes up once in a while. It's really, the way they look at it is really comparing the duty to protect the client with respecting the client's autonomy. Meaning 5, 10, 15 years later, the client may want a romantic relationship. And in theory, a counselor wouldn't want to interfere with that autonomy. Of course, the counselor would have to be willing to get involved in the relationship and there'd have to be no harm. But that's the logic that we see applied. And I just say it's simpler and I think more supported by evidence to say there's a lifetime prohibition. But either way, if a counselor introduces the idea of friendship or romance, I think of that as a very bad indicator. So moving on to the fourth sign of a less than ideal counselor. This has to do with incorrect diagnosing. And again, this is a little more objective than a lot of the items we see on these various lists. Now, one thing that's important to remember here is that I realize that everything in a diagnostic impression isn't going to be a technical, correct diagnosis, meaning it's okay to add supporting information. So if you see a diagnostic impression and there's a disorder and then there's an explanation of that disorder or some of the symptoms with that disorder, that's okay. For example, if you see major depressive disorder and then there's an explanation that says the client is unhappy pretty much every day, that's not necessarily technically excellent language for diagnostic impression, but I'm generally okay with something like that.
I'm going to disagree in a general way, and I don't think he's talking about a complete diagnostic write-up here, but if you, as a way to justify major depressive disorder, are simply saying they're sad all the time, that's not a very good qualifier, and you're going to want to have more evidence behind it, especially to qualify it for a DSM diagnosable and reimbursable diagnosis.
Because it's describing why the criteria might have been met for major depressive disorder. But what I'm talking about here is really much different. I'm talking about a few different things. So one is making up a diagnosis. And I've seen this so many times I've lost count. I've seen examples like angry person disorder. Again, there's nothing like that out there. That's not a real disorder. Talkative personality disorder. Some people are certainly talkative, but it's not a personality disorder. Super sad disorder. I guess this is as opposed to just regular sad disorder. Again, none of those are actual disorders. And I've also seen disorders that seem to be borrowed from trends, like the trend we see with the popularity of the construct of narcissism, like gaslighting disorder. Again, that's not real. Or narcissistic abuse disorder. Now, narcissistic abuse happens, but there's no disorder.
Now, I'm laughing as I hear this because, again, he's saying that he frequently sees people making up diagnoses. I have worked in this field for 25 years, and I have never come across an assessment with a made-up diagnosis. I have heard things worded really chaotically. I went through a psychological evaluation one time from a peer, and I'll never forget the wording. The therapist actually said, I might offer the following diagnosis, which doesn't look really good because it's not committing the diagnosis to permanence, and it's also not going to look really good to an insurance panel either who's reviewing your file. I have never seen a made-up diagnosis. And I'm wondering how this is happening so frequently, because here's the thing. Every diagnosis that gets reimbursed has a code to it. And that's how the insurance knows to pay for it or not. Major depressive disorder has its own code. There's some modifiers with it. Post-traumatic stress disorder has its own code. Generalized anxiety disorder has its own code. So he's saying he's seeing made-up diagnoses, and I'm thinking, how are these getting reimbursed? So I'm thinking, Grande may just be referring to therapists in private practice who take private pay clients. Because in this case, you're not submitting the diagnosis to insurance. But still, I'm thinking, this is beyond unethical to make up a diagnosis for a client. Because think about this. This client may end up going and seeing a different therapist. And that therapist requests the records. And they're going to see the documentation of these fake diagnoses on there. And that's going to raise all kinds of red flags. So again, if this is occurring with any degree of regularity, I didn't know it. And again, I would say I've also been very disciplined and have gone through a lot of training programs to really document well. And I'm sitting here feeling a lot better about myself because any documentation mistake I've ever made has never been due to making up a diagnosis. I find this laughable and at the same time such a disrespectful thing to do to a client. Completely disrespectful.
There's no narcissistic abuse disorder. We also see other terms that are based on trends like high-functioning depression. That's not a technical disorder. It really refers to a mild presentation of some sort of depressive disorder. So making up diagnoses, that's one problem. Another thing I see, and fortunately I haven't seen this too often, but does happen, is what I call weaponizing a diagnosis. To me, this is really one of the worst diagnostic practices and completely unethical. but again, it is seen sometimes. So we see this once in a while in substance use treatment, but we also see it in the treatment of other disorders as well. And what I mean here by weaponizing a diagnosis is when a clinician gives a diagnosis because they know there's a stigma associated with that disorder, in a sense to punish the client for having whatever symptoms the counselor doesn't approve of. So again, highly unethical. I've seen this done with antisocial personality disorder.
I don't know that I've ever seen a diagnosis used for punishment, but what I can really relate to that Grande's talking about is writing up an assessment in a way that's punishing toward the client. Because I've read lots of assessments that are so mean in how they point to the client in a negative light, really describing behavior. And I think there's a very, very ethical way to describe behavior that doesn't demonize a client. And if you're a good writer, and I consider myself to be a pretty good writer when it comes to clinical writing, I think I do a pretty good job of describing undesirable behavior without making the client into the bad guy. So I really know what he's talking about here. Again, I don't know that I've seen it done with the diagnosis so much, but certainly the write-up. And some of the write-ups you read really do make your client look like a terrible person.
Where when somebody comes in with a substance use disorder, like using heroin, for example, they're automatically assigned antisocial personality disorder. Those disorders have nothing to do with one another. So if they did, in fact, qualify for opioid use disorder, that would have nothing to do with antisocial personality disorder. Yes, there's high comorbidity between those two disorders, but the criteria still have to be met. Weaponizing a diagnosis is not okay. I've seen this done as well with borderline personality disorder, and I've seen it with substance use disorders where the substance use disorders are piled on when somebody doesn't meet the criteria. I call this stacking substance use disorders. So somebody comes in and they say that they've used heroin, and after talking to them it seems clear they would meet the criteria for opioid use disorder. But then they mention that they also have used alcohol in the past, marijuana, and cocaine. So instead of just really looking at those uses and determining whether the criteria for the disorder is met, the clinician simply stacks on the diagnoses.
This I have seen, and I saw it a lot more frequently in the past when I worked with kids, because I would see kids, I'm not kidding, 10 years of age, and they would have a stack of 7 or 8 diagnoses at the end of the assessment. Some of them were carryovers from other assessments, but a common couple of diagnoses you always saw were ADHD and ODD, attention deficit hyperactivity disorder and oppositional defiant disorder. But you would also see it with social anxiety disorder, generalized anxiety, major depression. You would see kids, again, as young as 10 and probably 8 even, maybe younger, with these stacked diagnoses that weren't given a lot of thought, or so it seemed. How are they justifying these? And I think a lot of times we as clinicians don't do a good job justifying our diagnoses, or we're not sure how to tease them out. So this stacking that he's talking about, I've seen it a lot. I tend to see it less with my adult clients, but it's there too. And you wonder how they arrived at this. And so as a tip for all of you that are writing clinical documents, justify what you're writing. You've got to justify it. If you're going to give somebody PTSD, you need to justify why you're giving them PTSD or depression or anxiety or any other diagnosis.
So stimulant use disorder for the cocaine, alcohol use disorder for the alcohol, and cannabis use disorder for the marijuana. So they just stack on the disorders, almost like saying, well, if this person uses one substance, they must use several, so I'm just going to pile on the diagnoses. Really a terrible practice and a very good indicator that you're working with a less than ideal counselor. I also see similar activities with weaponizing, but with disorders that are made up, like drug-seeking personality disorder. There's no such thing as that. Or taking psychosocial stressors and making those into a disorder, like outstanding warrant disorder. So somebody might write something like, this client may have trouble meeting appointments because they have outstanding warrant disorder. They have an outstanding warrant. It's not a disorder. That doesn't even make any sense. But we see things like that. Another indicator in the same problem area of diagnosing is when somebody describes a diagnosis fairly well without ever mentioning the diagnosis. That makes me suspicious that they don't know the diagnosis exists. For example, if somebody gives a primary diagnosis and then they go on to write that the client tends to eat substances that aren't foods, why wouldn't they mention pica? Why wouldn't they say something like, rule out pica?
So here Grande is asking, well, why wouldn't you put pica in there if you mentioned it in the course of your diagnostic or clinical write-up? Why wouldn't you come back to that? And so I'm going to do a little excuse making here for therapists. Most outpatient therapists working in a clinic will complete roughly 1 or 2 assessments a week, especially if they're younger, just coming into the field. It's sometimes 3 or 4 assessments a week. That tends to taper off a little bit as an older, more seasoned therapist, but I've known veteran therapists that have done 3 or 4 assessments a week. That is a lot of documentation. That is a lot of documentation. And remember, there's always pressure to keep the doors open at any agency you work with, so the paperwork's not going to slow down. You're going to miss something in this grand scheme of paperwork that we do. So when he's asking why something is left out, it's typically not going to be voluntary. You're just going to miss something. And if any of us goes back through all of our clinical documentation, there's stuff we've left out that we shouldn't have left out. Now, I believe to be the most ethical therapist I can be, I want everything in an assessment that needs to be there, but I want it written as succinctly as possible. I don't want to write for 13 hours on an assessment. Some people do that. But he's asking, why would something be left out? And that's my simple reason, because we're doing too much.
Now, just because somebody does that, they wouldn't necessarily meet the criteria. You still have to look at the criteria of the disorder, but it seems odd not to mention a disorder that lines up so closely with the description. And the last area of diagnosing I'll mention here is when the diagnosis is confused. Now, this happens to everybody. The DSM has a lot of disorders, so this isn't necessarily a clear sign of a less than ideal counselor, but some of these make me worry a little bit. For example, I've seen, in terms of what's been put down as a diagnosis, improvised explosive disorder. That's confusing improvised explosive device with intermittent explosive disorder. I've also seen intermittent wiper disorder, which makes no sense to me. The only thing I can think of that would happen here is that somebody typed in the word intermittent and perhaps the software suggested the word wiper, because I don't know what that would mean otherwise.
Intermittent wiper disorder. I have never seen that either. And this is a really good reminder to spell check everything you're doing in your documentation. And don't just spell check it, because spell check sometimes misses things. Print your stuff out, go through it, highlight what's off and correct it. That's a practice I had taken up many years ago. I don't do it nearly as much these days, but if I've got a wealth of information, I will print off the document and highlight mistakes I'm making. But this one's especially bad because that is an embarrassingly bad label to put on somebody. And how that passed through the person's auditing process, I have no idea, but that's bad.
I've seen examples like pre-traumatic stress disorder. It's actually, of course, post-traumatic stress disorder. I've seen ones that are more understandable, like major anxiety disorder. That doesn't exist, but major depressive disorder does exist, so I can appreciate that one. And the other thing I see is putting the specifier first. So like major depressive disorder, MDD, saying moderate MDD. Now, I'm actually okay with this. I don't think this is a major mistake. Technically, of course, it should come after. It should be MDD, moderate. But what bothers me is when the specifiers aren't real. So the disorder's real, but the specifier's not. Like subtle MDD or terrible PTSD. You can call a disorder subtle, and I guess you could also call a disorder terrible. It's not something that's really a technical term we would use, but you certainly wouldn't put it as part of the diagnosis. It would be in the descriptive information to support the diagnosis.
So he's really on point with this, that these modifiers, especially the made-up ones, cannot be anywhere in the diagnosis you give, because again, billing is going to flag that. That's not going to look right. But in terms of putting it in the body of your write-up, your diagnostic hypothesis, which is where you take everything you've written in your assessment and you sort of condense it into something that makes sense diagnostically, you absolutely can use that language. All the time, I have used phrases such as covert depression. And I got that term from Terrence Rill, who wrote a great book called I Don't Want to Talk About It, The Secret Legacy of Male Depression. And the book is really about how males are so less often diagnosed with depression than females because of their presentations. And so anger doesn't always look like a depression symptom, even though it is. So I've often written in the body of my assessment, it appears to have covert depression. It's not overt, okay, it's kind of hidden. But you're never going to put that in the actual diagnosis at the bottom of your assessment.
So moving on to the fifth sign of a less than ideal counselor, this is what I call the one-hit wonder. And this is where an individual has a dogmatic loyalty, an over-loyalty to one treatment modality. So what I mean here is one particular theory of counseling, like psychodynamic, Gestalt, reality therapy, cognitive behavioral therapy, existential therapy, one of the treatment modalities. We see it sometimes more with certain modalities than other modalities. For example, I see it quite a bit with psychodynamic, and I see it with motivational interviewing as well, even though that really isn't a comprehensive theory of counseling. But either way, again, this is an over-loyalty. So it's okay to have one modality and be committed to it.
I don't know many therapists these days that have just one modality or theory they work through. I don't think that's even possible. People are just too different. And if you look at populations that I specialize in, like personality disorders, there is no way you can just say, well, I'm a Gestalt therapist, I'm going to throw that at you, or I'm a cognitive behavioral therapist, because by the very nature of a personality disorder, it's not really conducive to cognitive behavioral therapy. Now, I believe there are therapists out there that are inflexible, and they're going to expect the client to mold to them. And I don't think that's okay. I think a better therapist takes these different strategies and theories and pulls them all together and uses them when they need to, kind of an eclectic approach. And I don't mean that in a sloppy way, because I don't think any therapist does just cognitive behavioral therapy. I think it's a great modality, but it's augmented by other strategies, even being present and listening with unconditional positive regard. We use that terminology a lot. That's a strategy. But very few therapists in this day and age are going to be able to succeed with just one modality or theory.
It's okay to be a psychodynamic therapist and really believe that the psychodynamic explanation makes sense for a lot of clients. What I don't think is a good sign, or what I think is a bad sign, more to the point, is when all other theories are then automatically dismissed. There's no recognition that any other theory could be valid because there's a dogmatic loyalty to one particular modality. And oftentimes what you find out when you talk to the counselor is it's the first modality they really liked. So they learned about a few modalities, they found one, and they committed to it, and they never bothered looking at another modality. So again, I call this the one-hit wonder.
I don't know that at any point in my training or education I ever subscribed to any one modality, so this is a little foreign to me. I was always taught to be, again, eclectic and pull together the best from every approach and strategy. And if a therapist, again, is unwilling to do that, I wonder, what is their fear? What are they afraid of? Or again, if it is the first modality that they learn, so what? Why not be open to learning other modalities to reach a broader client population?
One modality wonder, one theory wonder, something like that. Any of those would be consistent with what I'm trying to get at. So with the sixth sign of a less than ideal counselor, this is built around using the term more of an art than a science. I appreciate that not all counseling is scientific. There's also a philosophical component. What we would call an artistic component is there as well. So yes, it's not pure science, but this is an overuse of the term more of an art than a science, or more art than science. And when you usually see this term used in a less than ideal counselor situation is when you ask a question about a treatment goal, or how does the treatment really work? How does the modality work? It seems to me to be a way to dodge not understanding the science behind the modality and just to chalk it all up to art. It's really, to me, like saying you don't know the answer to the question.
So I don't know how many therapists are actually not explaining things by saying it's the art. I agree that if a therapist doesn't understand something, they should let the client know. I don't understand this. And I think every therapist should also have at least some understanding of the scientific underpinnings of why they're doing what they're doing. But I am going to advocate a little more for art than he's going to advocate, because I do think a good therapist does use artistry. I myself use a lot of sort of pictures and images when I describe things to people. I'm very metaphorical. I think that's very much artistry. And I've often said to people that the therapy I offer, the words are the palette and the colors. Now, having said that, I can explain to some extent the scientific reasoning and at times the biological reasonings for everything I'm doing with a client. Can I do it inside and out? No. Can I explain everything completely scientifically precise? No. Because as Grande is saying, I don't think therapy is a pure science. I think there are people that want it to be. Insurance companies certainly want it to be, because again, the precision to them is so important. But the artistry to me is a very important part of the therapy process. Unless, as Grande is saying, you're using it to say, I don't know what's going on, it's just my art. Good.
So I find that as a fairly distinct problem. I've seen that quite a few times, where counselors can't really explain the science of counseling. And instead of saying that, instead of saying, I really haven't read a lot on that topic, so I'm not sure of the science behind it, but I'll go ahead and check it out, they just move immediately to saying it's an art and not a science. So those are my 6 signs of a less than ideal therapist. And again, it's just my opinion, and you have to consider all the variables when looking at any of these signs. It's not so simple as to say if somebody has one of the signs, they're automatically a less than ideal counselor or a bad counselor or anything like that.
So, hey, this was Eric Nance, Dark Side of Therapy podcast. My critique of Todd Grande's critique of 6 signs you may have a bad therapist. If you like this video, please hit and please subscribe to us. Thank you.